घर पे भी कर सकता था।
हाँ घर से भी हो सकता है।
चलो, अटेंडेंस होती है क्या?
वो सर ऑनलाइन ही होता है, टेलीमेडिसिन से।
अच्छा, यूरोथ्राइटिस एंड सेक्शुअल
कॉपी करना डॉक्टर
जैसे मर्जी कर लो। तो यार आ गया होगा। रेडी की मतलब ये ट्रांसमिशन चल रहा है। ओके, गुड मॉर्निंग एवरीबडी. I don't know how many students are there. I can't see even a single one. इसमें can the students respond back? Hello? Is there any student on the other side? Hello? Okay. Is there any student on the other side? Hello?
तीन लोग हैं।
Is there any student on the other side? Apparently there are 3 students. Can you identify yourselves? Apparently there are 3 students. Can you identify yourselves? Okay. Aranya Datta is there. Aranya Datta is there. Ujjwal Gupta. Okay, the third student does not want to identify himself or herself. Okay, anyway, so I'll just begin. The topic for today is urethritis and stricture urethra, and you have already gone through your microbiology and pathology and pharmacology also, so you already would be having a reasonable degree of idea regarding what urethritis is. Stricture urethra is something which a lot of undergraduates do not know or understand at this stage, but I'll talk about that in greater detail. Urethritis, you must be knowing, can be either gonococcal or non-gonococcal or even autoimmune. And another new entity which is coming up is allergic. And I don't know whether normally I would have liked you to respond, but allergy to what? I can't get any feedback, but allergy to latex, the catheter material that is being used as for Foley's catheter. There is a small incidence of allergy to that latex, and that is also leading to a bad urethritis and bad stricture urethra. Although the incidence is not very high, but you can understand that the use of Foley's catheter is so common that even with a small incidence it can be a relatively huge problem. So urethritis, you all have read about gonococcal urethritis, and at the present estimate, this estimate is from USA by CDC Atlanta, the Center for Disease Control. They have estimated that right now about 35% of urethritis is gonococcal and remaining 65% is non-gonococcal. And the causative organism we all know is Neisseria gonorrhoeae, which is gram negative, and it's an intracellular diplococcus. The incubation period is typically short, 2 to 5 days, and in non-gonococcal urethritis it is longer. And you all know that this is a sexually transmitted infection, and in most cases you will you will definitely get a history of sexual intercourse, and asymptomatic in men is very uncommon. Only 1 to 3% of gonococcal urethritis would be asymptomatic. Usually the symptoms are rather severe and acute, and in about 30% of the patients there would be a double infection. There would be an associated chlamydial infection also. The clinical features: the patient would come to you telling that the patient has a frank pus discharge per urethra and is having burning while passing urine, and in milder cases there may be just some mild itching, frequency and urgency, but most cases in men with gonococcal infection they have a rather acute presentation. In women, the cervicitis may not be that symptomatic, and therefore that's the reason how it gets transmitted, because the women are not symptomatic, and all the so-called sex workers, a number of sex workers would be having that infection without having many symptoms, but the men who go to them, they will develop frank gonococcal urethritis. Diagnosis: clinical diagnosis is also reasonably obvious. Patient would have had a history of having had a sexual contact about 3, 4, 5, 6 days before, and would have frank pus discharge and a lot of dysuria. But still, for establishing the diagnosis, a swab has to be taken from inside the urethral meatus, and it has to be seen under the microscope after gram staining, and then it can also be cultured. On gram staining, more than 90% of the swabs would show the typical gram negative diplococci, and if those diplococci are not demonstrated, then on culture one can grow this organism on thigh and Martin medium. The typical way of obtaining the urethral swab is 1 hour after voiding from within the urethra and not simply from the drop of discharge, and a calcium alginate swab is normally taken, not a cotton swab, and the swab is inserted inside the urethra and it is rotated gently, and a DNA probe is actually more accurate than culture. It's more expensive and it can be time so in doubtful cases one can use the DNA probe test also. There's just, I'm telling you for the sake of completion of the investigations, but it is required practically very rarely. Treatment: this treatment chart is again from the Center for Disease Control USA, and ceftriaxone at the present time is considered the drug of choice depending upon the sensitivity in the community. Ceftriaxone is an injectable third generation cephalosporin. Penicillin has traditionally been the treatment of choice for gonococcus, but at the present time in the community there is a lot of resistance to penicillin. The other treatment regimes can include tetracycline, azithromycin or ofloxacin. In fact, these are given as additional treatment in addition to ceftriaxone, because these treatments would cover chlamydial infection, the non-gonococcal infection, and as I told you, about 30% of the patients would be having both the infections. So the recommended treatment is 1 injection of ceftriaxone, and in addition either 1 gram of azithromycin or 100 milligram of doxycycline twice a day for 7 days to cover for chlamydial infection. Cefixime is oral, and 400 milligram one single dose is adequate. That is an alternative to ceftriaxone, and even ciprofloxacin also has a broad coverage, and that can also be used. Ofloxacin will also cover gonococcus as well as will also cover gonococcus. Azithromycin and doxycycline for chlamydia. Non-gonococcal urethritis, the remaining 65% of men who present with urethritis would be having non-gonococcal urethritis. The etiological agents you would have read in your microbiology are Chlamydia trachomatis, Ureaplasma urealyticum, and Trichomonas vaginalis. The cause cannot be found in some of the patients, and there are a number of autoimmune situations that can also present with urethritis. The autoimmune situations that present with urethritis would also have a association with uveitis, the iridocyclitis in the eye, and there are some patients whom you may see in your life who have both uveitis as well as urethritis, and they are the patients who have autoimmune urethritis. And the systemic diseases like Stevens-Johnson syndrome and venous granulomatosis are the typical associations of urethritis. In non-gonococcal urethritis, the incubation period is long. The incubation period may vary from 1 to 5 weeks, and it is less severe. The discharge is not purulent, but it is mucoid or mucopurulent, and the discharge is less. And urethral itching is sometimes the most predominant manifestation, because the degree of dysuria may not be as bad as in gonococcal urethritis, and sometimes they can present with staining of the underwear. That is a typical presentation, that they will be having some mucoid or mucopurulent discharge, which would not be copious and which would typically stain the underwear. In the diagnosis, if you have obtained a gram stain for urethritis, you will find that there would be polymorphoneutrophils. The neutrophils, 5 or more per high power field, and VB1 means the voided bladder specimen 1. Sometimes in these patients you ask them to pass urine in installments. The first installment that comes is actually the wash of the urethra, and all the urethral secretions come in the first wash, and then there is a VB2 which is from the urinary bladder, and then there is a VB3 which is mainly from the bladder neck area. The culture, as I said, the swab is taken from inside the urethra, and Trichomonas is actually seen in the wet mount. Trichomonas is an amoeboid organism, and it can be seen in the wet mount of the urethral swab. Ureaplasma is more difficult to culture, and it's more difficult to establish, and you would have read in your microbiology that the culture methods for ureaplasma are relatively complicated. The treatment recommendations are based on chlamydial infection, and the recommended treatment is azithromycin 1 gram per oral or doxycycline 100 milligram twice a day for 7 days. Or instead of azithromycin, one can give erythromycin. Azithromycin is actually a long-acting erythromycin. It's from the same group, the macrolide group. Erythromycin, it has to be given for a longer duration, 500 milligram 4 times a day for 7 days. And ofloxacin is fluoroquinolone, which has to be given 300 milligram twice a day for 7 days. The treatment for trichomonas, as for amoebiasis, is metronidazole 2 gram orally, a single dose. So this is a quick table comparing the gonococcal and non-gonococcal urethritis. Typically, gonococcus is seen in lower socioeconomic group, non-gonococcus is seen more in high socioeconomic group, and the causative organism is Neisseria gonorrhoeae in gonococcus and Chlamydia trachomatis in non-gonococcus. Incubation period is short in gonococcus, it's longer in non-gonococcus, and asymptomatic carriers, especially in women, I have already talked about. The discharge is purulent and copious in gonococcus, and it is thin, mucoid and scanty in non-gonococcus. The gram stain would show gram-negative intracellular bacilli, the diplococci in gonococcus, and you will typically see the inflammatory cells. The establishment of the organism is more difficult, and therefore the treatment is more empirical. And the treatment for gonococcus is either ceftriaxone, cefixime or ofloxacin, and the treatment for non-gonococcus is doxycycline, azithromycin, and metrogel is for trichomonas. The infection can travel up from the urethra, go into epididymis, and can cause epididymitis or epididymooccitis. The other big problem is of stricture urethra. Sometimes the episode of gonococcal urethritis is forgotten, and many years later the patients come with stricture, and the stricture is generally bad. It's a reasonably long and reasonably dense stricture, and the treatment is generally reasonably complicated. Very rarely the gonococcal infection can go into a gonococcal septicemia kind of a picture, and the Ritter syndrome we have already talked about. Ritter syndrome is the complex of urethritis and uveitis, and it is generally seen as an allergic or an autoimmune reaction to non-gonococcal urethritis. Coming to the topic of urethral stricture, these two diseases are in fact separate diseases, but because urethritis can lead to urethral stricture, that is why these two have been put together in one lecture. Urethral stricture is a reasonably bad disease, because it actually is because of the scarring of the corpus spongiosum, and once the corpus spongiosum is replaced by fibrous tissue, then it is replaced with fibrous tissue for life. And whatever treatment you do, the treatment is generally temporary, and the stricture or the narrowing of the urethra keeps on coming back, and in most patients generally it's a lifelong problem. And there are ways to actually control, and there are some surgical methods to cure also, but most of the time it's a disease which is a lifelong kind of a disease. So the definition of stricture urethra is, it is a scar of the urethral epithelium extending into the underlying corpus spongiosum. It is the corpus spongiosum which, when gets replaced by fibrous tissue, that is what leads to stricture urethra. The epithelium is the mucosal lining, the inside lining, but if only that is damaged or inflamed, that can get replaced and stricture would not happen. It is only when the corpus spongiosum gets inflamed and later on scarred that a stricture would occur. And the collagen is, a lot of patients are generally young, and young patients, their healing is also stronger, and their corpus spongiosum gets replaced by dense collagen and dense fibroblastic reaction. And a little bit of narrowing of the urethra is tolerated. There is not much narrowing of the urinary stream, but if the urinary stream becomes reasonably, if the lumen becomes reasonably narrow, only then the urinary stream would become thin, and patient would present with straining at urination. Just a little bit of recall of the anatomy. The urethra, in the penile part of the urethra is divided into penile part, bulbar part, membranous part, and the prostatic part. The penile part is the one which is in the pendulous urethra, is also called as the pendulous urethra. In the penile part, the urethra is in the center of corpus spongiosum, but in the bulbar part, which is in the perineum, The bulbar part has a thicker corpus spongiosum on the ventral side and a thinner corpus spongiosum on the dorsal side. Therefore, the lumen is more on the dorsum compared to the center, and this is important when we are selecting the site for internal urethrotomy. Internal urethrotomy is a surgical procedure in which, by means of endoscopic guidance, you put in a knife which is thumb controlled, and that knife, I'll just show you the knife also in one of the slides. That knife can cut open the lumen, and that is what is known as visual internal urethrotomy. Under vision, you do an internal opening of the urethra, internal urethrotomy. We also have to know the blood supply. The blood supply of the urethra is from the common penile artery. The common penile artery gives a reasonably big size branch, which is the proximal bulbar artery, and the distal supply is by dorsal arteries of the penis. There are multiple circumflex arteries all around the corpora, all around the corpus spongiosum, and there are tiny communications between the corpus spongiosum and the corpus cavernosum. The deep dorsal artery of the penis supplies the corpus cavernosum, one on each side, and the main blood supply into the penis is into the corpus cavernosum, that is what is responsible for erection. And from the corpus cavernosum there are tiny vessels which go into the corpus spongiosum. The distal part of the glans also has its blood supply, which is again the terminal branch of the common penile artery. Apart from stricture urethra, although the accidents are also a very important cause of stricture urethra, the fracture pelvis and urethral disruption, it is not called as a stricture. The terminology that is used these is urethral distraction. Urethral distraction, it is called distraction because the bulbar part of the urethra gets distracted from the membranous part, and the two parts are actually lying far away from each other, and there is hardly any communication following a major accident and fracture pelvis. So it's called a urethral distraction defect, and previously that was also included in the topic of stricture urethra. But definition wise, stricture urethra is basically a narrowing rather than a distraction, but the surgical principles are similar, and therefore they can be grouped together in one group. You would have all seen this picture in Bailey and Love, that there is a man who is walking on the street and there is a manhole, and the manhole has suddenly got vertical because he has stepped on one side, and that has hit his perineum. The perineum, so a blunt perineal trauma, this can also happen if a person is riding a bicycle and suddenly the bicycle has some kind of an accident and the perineum hits against the rod, the horizontal rod of the bicycle, and that perineal trauma can, if it is deep, it can lead to an injury of the bulbar part of the urethra, that is known as a straddle injury. The other common cause that is coming up is actually instrumentation. All the instrumentation that is done either as a diagnostic cystoscopy or for prostatic surgery or for stone surgery. So all the surgical procedures that we urologists do, that can also lead to a damage. And we have already talked about gonococcus and non-gonococcal, and then another disease which is relatively common in people who have poor perineal hygiene is known as balanitis xerotica obliterans. Balanitis xerotica obliterans, there are whitish atrophic plaques involving the glans and the prepuce and the meatus. What is the causative organism or what is the exact pathogenesis, that is not known, but typically there is a slow smoldering inflammation which can be demonstrated pathologically, and that slowly keeps on leading to initially a meatal stenosis, then a submeatal narrowing, and slowly and steadily the entire urethra, the entire corpus spongiosum can get involved and can get scarred. Some of the really long strictures that we see are the result of balanitis xerotica obliterans. Oh, there is a spelling mistake. It is balanitis. That one T is missing. Balanitis xerotica obliterans. What are the clinical features of stricture urethra? The typical clinical feature would be obstructive voiding symptoms. The patient would have to strain to pass urine, and there is a progressive increase in the degree of straining that the patient would be a relatively youngish patient in 20s or 30s, and or sometimes there may be, because of meatal stenosis or a submeatal stenosis, there may be some kind of a showering kind of a splayed urinary stream, and on examination you may find areas of urethra that are, the entire urethra can actually be palpated. The penile urethra is on the ventrum of the penis, the bulbar urethra is palpable in the perineum, and the prostatic urethra can be palpated per rectum. The prostatic urethra would very rarely get involved with a stricture unless it's a post prostatectomy situation. So most of the causes of stricture urethra that I have talked about would not involve the prostatic urethra, and the prostatic urethra will only get involved by a surgical intervention, either in the form of open prostatectomy or a transurethral resection of the prostate. Sometimes there may be an infection in the glands of Letter which are in the urethra, in the urethral wall, and those glands can get converted into either small abscesses or into relatively big abscesses also, and these abscesses can sometimes rupture through the skin and can lead to urethropectaneous fistula. So there may be some tender urethral abscesses, which is a complication of stricture urethra. A peak flow rate, there is an investigation called uroflowmetry. You might have seen some of the patients getting this uroflowmetry done in the OPD. Uroflowmetry is an investigation where the patient voids in a pot which is connected to the computer. The computer calculates the average flow rate, the peak flow rate, and I'll show you one of the uroflowmetry printouts also. So how do we evaluate in a patient who is suspected to have a stricture urethra? The first investigation that we get done is a uroflowmetry. Uroflowmetry will typically show reduced peak flow rate and a reduced average flow rate, and the pattern of flow would be what is called as a box shaped pattern. The flow will, I'll show that to you later on. Once it is reasonably certain that the patient has a stricture urethra, then we need to establish what is the length and what is the exact site of the stricture and what is the degree of tightness or what is the caliber of the urethra. And for that there are two investigations which are generally advised. One is a retrograde urethrogram. In a retrograde urethrogram, the urethra is filled with a radio-opaque dye. Generally it is urographene, and in voiding cystourethrogram or a micturating cystourethrogram, the bladder is catheterized with a thin catheter, and it is filled, and then the patient is asked to void, and during the voiding the urethra is evaluated. The retrograde urethrogram is a reasonably accurate way of establishing all these issues: the length of the stricture, the location of the stricture, the tightness of the stricture, and to some extent the functional significance of the stricture. So this is a retrograde urethrogram. You can see that there is a nozzle of the syringe that has been put inside the meatus, and the dye is being injected and the urethra is being delineated, This patient has a relatively bad stricture. If you can see my arrow, this is the bulbar urethra, which is reasonably normal. This again is the bulbar urethra, which is normal. A little bit part of the penile urethra or the pendular urethra is okay, but rest of the penile urethra is all tight, and you can see because of the pressure the dye is going into these tiny glands, which are the periurethral glands. So this is some kind of an intravasation or extravasation of the dye outside the urethral lumen because of the pressure, because of the tightness. So here in this patient you can see most of the urethra is actually normal. Here you can see the verumontanum, and this is the prostatic urethra. The prostatic urethra is seen as a normal chink. This smooth narrowing is actually the membranous urethra, or the area where the external sphincter is, and this is the bulbar urethra. The bulbar urethra should be actually like a big bulb, but here you can see that there is a shouldering kind of an effect, and this is the area of the stricture. This area of the stricture is seen in both these films. The retrograde ureterogram has to be done in an oblique position because you don't want an overlap with the bones. You want the urethra to be delineated. Look at this. This is a patient who has a very, very bad stricture. The entire penile urethra, the entire bulbar urethra, very, very little of the proximal bulbar urethra is spared. Very small area. This is the membranous urethra, and this is the prostatic urethra. The bladder is also showing irregularity because of hypertrophy. So this entire urethra has to be repaired. This is the uroflowmetry that I was talking about. The flow is hardly going beyond the baseline, and it's what is known as a box-shaped pattern. It comes up and then it remains flat, and then it falls down suddenly. Ultrasonogram is one of the techniques of establishing the density, and in that jelly is put into the urethra, and by a surface probe, this is known as sonourethrogram. So only in patients who have a relatively small short area, especially in the bulbar area, is it important if you want to establish how bad the stricture is. On most situations we actually go by retrograde ureterogram or micturating cystourethrogram and endoscopy. With endoscopy also you can not only estimate the lumen, but also by the color of the urethra you can find out how bad it is. Normal urethra should be pinkish. If it is white, then it is generally a scarred urethra. There are lots and lots of complications of stricture urethra. It leads to urinary tract infection reasonably commonly. It can lead to prostatitis, it can lead to epididymitis, it can lead to periurethral abscess, it can lead to a urethral diverticulum, it can lead to a urethropotaneous fistula, it can lead to a bladder stone, it can even lead to renal failure, and patients can die of renal insufficiency. And in patients with long standing stricture, they can have squamous metaplasia and a squamous cell carcinoma. So the management, there are lots and lots of options available that will basically depend upon the degree of tightness and the length of tightness. If the degree of tightness is mild, then you can just dilate the urethra, and you can dilate the urethra off and on, and that can lead to a satisfactory opening of the urethral lumen, and that may be adequate. Internal urethrotomy, as I have already talked about, is putting in a urethroscope inside the urethra, and there is a thumb operated knife which comes in and out, and that tiny knife you can manipulate, and you can specifically open certain areas of the urethra. That is known as internal urethrotomy. And excision and primary anastomosis. If there is a small, short, localized, dense stricture which cannot be cut, then that part of the urethra can be excised, and the proximal part of the urethra can be anastomosed to the distal part of the urethra. If only one wall is mainly scarred, then that wall can be replaced by a free graft. The typical free graft that we take is from the inside of the cheek, or the buccal mucosal graft. So the buccal mucosa has characteristics which are similar to that of the corpus spongiosum or urethra. So a graft can be harvested, and that wall of the urethra can be replaced by a free graft. Then there are island flaps. The blood supply based flaps. The flaps can be rotated, the skin flaps can be rotated either from the prepucial skin or from the penile skin, and one wall of the urethra which is scarred can be replaced. Or in patients who have relatively long and bad scars, one may need very long islands, and even the scrotal island flap may have to be used. And then in very, very complex situations, sometimes one has to take the help of plastic surgeons and harvest radial forearm flap and do even more complicated procedures. So the simplest way of handling a stricture urethra is urethral dilatation. It does not lead to a cure, as I've said, because scarring is always permanent, but if there is just a mild narrowing, then it may be curative in those patients who have minimal spongiofibrosis. The care that should be taken is it should be a very, very gentle dilatation. The scar should be gently stretched, and it should not lead to further damage of the urethra. If there is a further damage of the urethra, and then there would be further scarring, and slowly with time actually the problem would get aggravated. So you must be extremely gentle in your dilatation, and the long-term success is, as you can understand, is poor, and it is mainly meant for those who have a relatively minimal kind of a spongiofibrosis. Then internal urethrotomy is something which is significantly more, or you can say beyond urethral dilatation. In urethral dilatation, it's a slow dilatation, but in internal urethrotomy, you are cutting open the lumen, which is tight and narrow. In the penile urethra, one should cut at 12 o'clock. In the bulbar urethra, one should cut at 2 o'clock and 10 o'clock. The 6-month success rate of internal urethrotomy is to the tune of 70 to 80%, and there would be recurrences. Sometimes you may have to repeat it, and if after doing the internal urethrotomy on 2 or 3 occasions, if it does not stabilize, if the urethra does not stabilize and keeps on getting narrowed again and again, then one may have to do a urethroplasty. So urethroplasty, as I have already told you, is of various types. The common urethroplasty that we generally do is what is end-to-end urethroplasty. This is mainly done in patients who have a urethral distraction, where one end is lying somewhere else, the other end is lying somewhere else, and those patients who have had a rupture of the urethra or a distraction of the urethra due to a road traffic accident, generally associated with fracture of the pelvis. And if the distraction defect is less than 2.5 centimeters, then the success rate is very good. Almost 95 to 100% of the patients, they are completely cured of their problem. So what basically is done is that the urethra from the penoscrotal junction to the proximal bulb is mobilized, and the entire scar tissue is excised, and then the urethra is spatulated, and there is a mucosa to mucosa anastomosis between the apex of the prostate and the bulbar urethra, and the success rate is very good. But as I mentioned, if there is only one wall of the urethra that is involved, then one can use a graft. The graft can be from a penile skin or a buccal mucosa or a bladder epithelium. The commonest that we use is the buccal mucosa. That is the easiest to harvest and easily available, and it generally does not lead to any scarring inside the mouth. And the tissue texture is quite similar to the urethral texture, and take rates are pretty good. Take rates almost 90%, and the success rate of this surgery is almost to the tune of 90%. It can be an onlay technique or an inlay technique. An onlay means that the defect that you create by excising the scar, you can put on it, and or you can fit it inside the lumen. That is inlay technique. And generally it should be done on the dorsal side, which means that the entire urethra should be circumferentially mobilized, and the opening should be made in the dorsal part, and whatever defect is created in that part, you should fit it in. In patients who have really bad strictures, you may have to do a 2-stage urethroplasty. In patients who have had failure of the first attempt at urethroplasty, you may be forced to do a 2-stage urethroplasty. Or those patients who have had bad complications like a urethroperitoneous fistula or an abscess, or if the local tissue is not good enough, then you may, in the first stage, you may just have to open up the entire urethra, and in the second stage you may have to tubularize. You may have to first open up and augment with either a buccal mucosa or some kind of a skin, and then later on tubularize. I'll show you some of the pictures. So the flaps are the vascularized flaps, which means that they are mobilized on their own blood supply, and the blood supply remains intact, and then they are rotated, and they are the ones which are used for replacing the wall of the urethra. So the typical commonest one is what is known as Orandi's flap or a penile skin flap, and then there are other quatty flap, the preputial island flap, and for bad cases the long ones, scrotal island. The problem with scrotal skin is that there are hair, and hair, if they are incorporated in the urethral lumen, they can in the long run lead to stones, and then those urethral stones will have to be taken out endoscopically. So the non-hair bearing area of the scrotum, which is right in the midline, that should be preferably taken. And so this is some kind of a management algorithm which is available in the books. I have already told you the details. This patient, he is on a suprapubic catheter. He has had a bad road traffic accident, a fracture of the pelvis. You can see he has had multiple split skin grafts. These are the donor areas of his split skin graft, and he has used some kind of a nala to stabilize his SPC catheter. The urethra is not seen well, but you can see that there is a good amount of scarring that is present in the glandular area. It is all whitish and scarred. This is what is an internal urethrotomy. This is a telescope that you put in with this thumb operation. If you push in the thumb, the knife comes out. If you pull out the thumb goes in. The knife goes in. You put the knife into the narrow part of the urethra, and then you cut it, and slowly you can keep on opening it. So this is internal urethrotomy. This is a patient who has a bad distraction defect. This entire urethra is missing. This is a combined study. A retrograde uretrogram has been done and a micturating cystourethrogram has been done. So from above, the dye has been put in. It's a micturating cystourethrogram. This shows that this part of the urethra is normal, and retrograde uretrogram which shows that this part of the urethra is normal and this part of the urethra is actually missing. He is a patient who had a road traffic accident. This is another patient who had a bad road traffic accident. You can see all this is the callus. This is the SPC and the dye has been filled in from here, the bladder neck is not opening up at all. So there is a huge long defect, a distraction defect. This is another patient who has a very bad stricture. This is, you can see, he has had a fracture of the femur, and the femur has been fixed, and the bladder neck is not opening. There is a healed fracture of the pubic bone also. Another patient with a this is the same patient. There is a block at the bladder neck. This generally sometimes happens in small children who have a road traffic accident and who do not have a big prostate, that the bladder neck gets disconnected from the prostatic urethra. Occasionally that kind of an accident happens. Another patient with urethra missing at 2 points. This is a patient who has had hypospadias repair, but the skin tube that has been used is all sacculated, and he has stricture at 2 points, and it is a sacculated urethra which needs correction. These are the bladder stones that have developed secondary to the stricture. You can even see there are big urethral stones that have developed because of the stricture. And the same patient having big urethral stones and big bladder stones secondary to a stricture. Really patient who has been neglected and who has had a bad. And this is a diverticulum. There is a bladder diverticulum that has developed because of the stricture urethra, and vesico-ureteric reflux because of the stricture urethra. So you can see that in micturating film the entire left-sided pelvic ileal system is shown. Long anterior inflammatory stricture, typically long, either because of gonococcal urethritis or because of balanitis xerotica obliterans. The entire urethra needs to be replaced. 2 strictures in the bulbar urethra. This is what is known as a Knutson's clamp. There is a clamp inside of your hand. You can squeeze the urethra with a clamp and do a retrograde urethrogram. This is a retrograde urethrogram. There are 2 strictures. Again 2 strictures. 2 strictures are uncommon, but yeah, sometimes they do happen. Multiple strictures can happen. They are not uncommon. In gonococcal urethritis they can happen relatively frequently. One patient having 2 strictures. This is one part of the urethra, this is the other part of the urethra. This is an in between normal urethra which is being anastomosed. This is a patient with balanitis xerotica obliterans. All this whitish patches, these are xerotic patches, and the entire, you can see a very tiny pinhole meatus. This patient the entire urethra was first laid open. And then a buccal mucosal graft was put in, and then subsequently it was retuberized. The whole urethra was all scarred. So a 2-stage procedure has been done. This is how the buccal mucosal graft is obtained. You can see the Stenson's duct. The Stenson's duct should not get involved, and this is the harvesting of the buccal mucosa. And this is the buccal mucosa that has been harvested, and this is in the defect. The entire urethra has been opened, and in the scar, after excision of the scar, the defect that is created, in that defect this buccal mucosa is stitched, and then later on it is tubularized and a new urethra is formed. So that is the end of the formal presentation. I don't know how to get back questions from you. I think I'll stop here. If there are any questions, then you can get in touch with me. ये questions का कैसे होता है इनका? No questions. Okay, then thank you very much. You want penile and scrotal flaps to be repeated. Okay. Penile flap, the typical penile flap is what is known as an orandi flap. An orandi flap is basically used for a penile stricture, for a pendular stricture. In a pendular stricture, if the lumen is very narrow but there is some lumen, then in that case you can augment that lumen by rotating a penile skin flap. So what you do is you take a longitudinal penile skin flap. So you lay open the urethra, the pendular part of the urethra, and you kind of flip a penile skin flap. So I'll try to draw a diagram. Can you give me some paper? So you can imagine that if this is the penis, the first thing that you do is you lay open the penile narrower part, and then the skin which is adjacent, you take a rectangle, a long rectangle, and you stitch this, and then you rotate the flap and you tubularize it, and then you can cover the defect of the skin by so that is what is known as an orandi flap. A scrotal flap is actually used for very complex strictures where the deeper part of the bulbar urethra also has to be replaced. So in that, what typically is done is U-shaped flap is taken from the, so here if you can imagine, this is the anus, these are the buttocks, and this is the patient who is in the lithotomy position. So from the perineum, in the base of the perineum, you take a long inverted U flap which goes into the scrotum, and you kind of tend to take the midline part of the scrotum, and then that part is tubularized and it is taken up almost till the prostatic apex. And then in the second stage, the perineal tube is connected to the penile tube. So that is what is, there are the scrotal flaps are the Turner-Warwick flap and the Blandy flap. So these are the two urologists from UK who are now very senior, and they are the ones who described these two flaps. I hope, Aranya, that is clear. If it is not clear, you can meet me anytime and I can explain it to you. Or if there are any other questions, you can. Okay, then goodbye. It's already 9 o'clock. Thank you very much. सिर्फ 2 ही स्टूडेंट्स थे आज.
सर इसको करना.
अच्छा, ये भी